Hello everyone, Santiago Brian here, and I have another qEEG. This time we have a motocross athlete who came to see me a couple of weeks ago, and we're going to do the interpretation of this qEEG and show once again the importance of looking at the athlete's brain in order to do a better, more efficient and efficacious intervention. So this is a male motocross athlete, and he came to me and was referred by a colleague of mine, sports psychologist who works with him in a different city. He lives outside of Bogota. And he was referred because he's reporting cognitive issues, problems with his focus and memory, remembering things, being able to withhold information to use later, remember that information for posterior usage. So we're going to see what the brainwaves are telling us here, and hopefully we'll be able to get a clear assessment and develop an integrative approach, including neurofeedback, nutrition, medicine, and physical therapy, and other sciences and professions to help this athlete overcome his obstacles, feel healthier, and perform better. And as always, we start by looking at the amplitudes of the brain waves. And then again, we have slow brain waves here that are high in amplitude. So the higher the amplitude, the size of the brain wave, the slower the frequency or the speed. And we may also find fast brain waves, such as this right here, which are smaller in amplitude. So the smaller the amplitude, the faster the frequency or the speed of the brain wave. And the first thing we look is to see which ones are dominant or more prevalent. And we start seeing here the frontal cortex, the midline FZ to F4, we have some slowing, going down to CZ, the midline, T5, left posterior temporal lobe, T6, right posterior temporal lobe. So we have some slowing taking place, and if we scroll through it, we'll see that T5 has a permanent, presenting constantly, slowing right there. And we have the same activity at FZ and F3, F4 with the slowing at T5, some posterior slowing, which is going to be relevant for our interpretation. So by looking at this, I'm already drawing and thinking about some ideas about what could be, what this athlete can be presenting with. Now, I want to go through, and if we see, we have a combination of slow brain waves, some fast brain waves, but for the most part, the dominant activity is that of slow brain waves with high amplitudes. And I want you guys to notice this because we're going to go revisit this segment right here later on in the interpretation. So I have some slowing of the EEG. I have slow brain waves and some fast brain waves. For the most part, like I said, is the slowing and the theta and alpha, some delta range that are more present, more prevalent, more noticeable in the EEG. And again, the visual inspection of the EEG is the most important aspect, because you might be presenting with some EMG or muscle tension or some other kind of artifact such as eye blinks, eye movements, or even a faulty cap, a faulty wire that could be causing activity that could be confused for real brainwave activity. So it is very important to read this EEG to do good editing, good de-artifacting, and then a good interpretation of it. Otherwise, we're going to be confused. And if for somebody who's not trained with the visual inspection of the EEG, they're going to look at the topographies and find slow activity at the front of the head, when in reality it's just eye movements, eye blinks. Or you could find a lot of beta activity at the temporal lobes or the occipital lobes, and in reality it could be just muscle tension. So for instance, we have some muscle tension here, a little burst of muscle tension that could be confused. If it were present all the time, somebody could confuse it with extreme beta activity, when in reality that is not the case. So for the most part, we have a good clean EEG, and then we have the same activity that I showed you a few seconds ago here present again, and then I want you to bookmark and make a mental note of that. And we are going to revisit that because it's relevant to this athlete's performance, health, and for interpretation purposes. So again, T5, a continuous burst of slow brainwave activity, and we have some phase stability from the front to the back of the head in the theta alpha range, which is going to drive up coherence. So we have hypercoherence here, and we've seen that burst once. We are very likely to see it again, and there it goes again. And what that means is the brain going offline, shutting down for 1, 2, 3 or more seconds, and so the athlete is losing the ability to perform any cognitive tasks efficiently, such as focusing, remembering things, planning the strategy for the competition, staying calm, staying present without too many distractions while he is performing. And here it is again, 396 seconds, burst of slow brainwave activity, which is presenting with phase stability, and the same pattern at FZ to F4, which is relevant again. So we have slowing in the alpha and theta range, which means the brain is not getting enough oxygen or enough glucose for it to work properly. Here we're presenting with a burst of EMG and some kind of electrical artifact, probably a cable swing or the cap moving suddenly, a sudden tilt of the head, which would cause this. So it's just going to mark it as an artifact. And it's going to be taken out. Here's more EMG. So if somebody doesn't know how to interpret this, doesn't know how to do the visual interpretation of the EEG, is going to think this is real brainwave activity. And if they only go based on the topographies, well, they're going to have false positives, and we're going to have a faulty interpretation of what's going on here. Again, so slow brain waves, for the most part, a brain that is getting tired very quickly because there's hypoperfusion, low blood flow to the brain, which means low oxygenation, lower glucose metabolism, and lower glucose usage. So a brain that's going to require extra energy and has to work extremely hard to help the client to do things in a proper performance enhancing way. Here's another burst of slow brainwave activity. So again, we have that hypercoherence due to phase stability from the front to the back. And that's not a good thing because the front and the back of the head are supposed to take turns when it comes to using for doing what it's supposed to do for either visual field or focus or executive functioning, anything like that. And what we have here is the front and the back of the head fighting for that resource. They're going on at the same time. And so what that causes is the brain to go offline. So what's happening is at certain points, the front and the back of the head are not taking turns. They're both trying to operate at the same time. And that's never a good thing because that's not possible by any standards. So what that's going to cause is the brain just to go offline, and the athlete's going to lose the ability to perform specific tasks at specific periods of time. And what I'm doing here, we have some beta spindling, but it's covered by some EMG, so I'm just going to delete that. We don't want that in the interpretation. It's not going to cause any trouble, but we're just going to do that. And then again, we have the same activity here. The frontal cortex, the midline to the right frontal lobe, which is relevant. So by looking at the slow brainwave activity and the pattern, we can start making certain assumptions and throwing certain hypotheses and theories as to what is affecting this athlete and what the background is. So slow brainwave activity normally correlates with low glucose metabolization. So the brain is having trouble metabolizing the glucose usage, and it's having trouble using that fuel properly for it to do what it's supposed to do more efficiently. Slow brainwave activity can also correlate with brain inflammation, which is the case in this interpretation. There's some brain inflammation going on. It also could correlate with a TBI, a traumatic brain injury, but it could also correlate with some organic deficiencies. The thyroid could influence that. Liver problems can influence that. Insulin resistance could influence that. So in addition to looking at this EEG, it's also very, very important to do a full, thorough medical assessment in order to find out organically what could be affecting this athlete and also what could be affecting this brain right here. But for practical purposes, and since we don't have any medical evaluations yet, he's at the moment of this record, he should be going to the functional medicine doctor and the other practitioners that work with him to do a full medical nutritional assessment in order to find out what else is affecting his performance and what else is affecting the brain here. But this athlete is a motocross performer, and he had a TBI, a traumatic brain injury, about 15 years ago, when during a practice he was performing a jump and he collided mid-air with another motocross athlete. So they both performed the jump at different points in the track, but they both collided in mid-air and fell to the ground. And once he fell to the ground, he lost consciousness, and they had to perform a surgery to relieve craniotomy to release the pressure from the skull and keep the brain from swelling up. And after that, the athlete reported that he had seizures following the surgery that had to be controlled with medication. So as a background, we have a traumatic brain injury. We have an athlete who is presenting with certain patterns. And the slowing in this case is going to make sense as far as the TBI goes, but as far as the consequences of that TBI as well. So remember that he was referred because he has problems focusing, remembering things. His short-term memory is highly compromised. And so we are starting to see behavioral and functional consequences of that. Now, going to the element that I told you about, I want to begin with that because it's really important. So we have at FZ, the midline, we have some slow brainwave activity in the theta range, in the alpha range, which is really affected athlete. If you notice, there's field and phase to F4. Not so much to F3, but F4. So it's the midline to the right frontal lobe, and we have some field and phase, meaning it is FZ and F4, the source of that discharge in particular. And that slowing is giving us a warning. It's a red flag for something taking place there, something we should be mindful of and pay attention to. And so if we move forward, I want to go to that same activity, FZ to F4, F3. But we're going to be noticing more clearly somewhere over here. So what I'm going to do is find it and show it to you. And here it is. If I scale the sensitivity here, This is normally how we see it, but we can change the sensitivity to see it more clearly. And here it is. And what this is a spike and wave complex. It's a epileptiform discharge that this athlete has as a consequence of that TBI, and it's located at the midline FZ, anterior cingulate cortex, to F4, F3, so the right and left temporal lobe. Now, because the amplitude is high at FZ and F4, the source for that particular discharge is going to be the midline and the right frontal lobe, with the activity percolating to the left frontal lobe and the right and the left of the brain, as we can see right here in this child right here, this part, in this section right here. And if I move forward, the tendency is if you see it once, you're likely to see it again. And here it is again, clear as day, spike and wave discharge, FZ to F4. And that was a little more subtle. Again, seen here. And again, seen here. So FZ to F4 with a higher amplitude of discharge is taking place over there, and then discharging and percolating to other areas of the brain. Now, remember this athlete told us that, or told me, that he had seizures following the surgery, but he reports not having seizures for the last 15 years since he was discharged from the hospital. So again, F3 to F4, F3 to FZ to F3 and F4 here, and then the slow and discharge right there, with the theta range, delta range going on. So since he hasn't reported any convulsions or seizures, nobody bothered at looking at it from a functional perspective and thought that he was functioning rather well. But as we can see, here's the discharge again, F3 to F4. Here's the amplitude, some FP2 as well. So it's the right midline to the right side of the brain, percolating to the left, and then discharging to the other side of the brain. But here is the spike and wave complex with the posterior slowing characteristic of that discharge, that it's affecting the athlete's performance and putting him at risk for developing or redeveloping a seizure disorder here again. At the present time, he's not being treated with any medication, or he's just being worked on or intervened on with traditional sports psychology methods, which are okay for his sport performance. But thankfully, the colleague understands the value of doing a qEEG, and when he noticed certain patterns of behavior, he decided to refer the athlete. And here we have the ending result of that brain injury and what we're observing right now. Here's the discharge again, FZ to F4. And so whatever the discharge is presenting itself is going to be relevant to what behaviors and skills in general are going to be affected. Here's the slowing with the face stability. And here it is again. So we have a clear understanding now what's going on with this athlete. So we have a discharge, the frontal midline to right brain. Here it is again. So we are noticing that this brain needs to be intervened rather quickly, so that we can not only enhance and improve his performance, but also his health in general. So we have that there, and there are other patterns that are capturing my attention. So for instance, we have T5, which is Wernicke's area. That's verbal memory, short-term verbal memory. And if we see, we have slowing right there, which would indicate going to go out on a limb and assume, I may be wrong, but I'm going to assume that's probably the initial point of impact as when compared to T6, which is the right side of the brain. So it could be a, a coup and contra coup here from temporal lobes, and which had a midline impact, which would mean the corpus callosum could be compromised as well. And so we have that here, that's slowing there, and that what that is showing us is memory compromise. Short-term memory is compromised, and this athlete has that. When I was talking to him during the interview, the initial assessment, I noticed that he would ask the same question 2 or 3 times because he just forgot what I had just told me, and he would forget what he had just asked me. So we need to target that area with some neurofeedback and other intervention supplementation. Now, going back to the discharge, what I would do and what I did is to refer this athlete to a neurologist and sent this file to the neurologist to corroborate this activity, and not only to have the neurologist corroborate that that is right, but to have the neurologist sign off on the report and the assessment as the medical practitioner licensed to do so. So what I'm doing here is just providing an interpretation for the athlete and then referring to the most to the right professional. I don't use ideal professional to do the assessment and sign off on the report and provide any additional diagnostics. So we have T5, and then we have our discharges that are going from the front to the back of the head with a phase stability, which means the brain is going offline. So if you are competing and the brain goes offline for 2.5 seconds, 1.5 seconds, even half second, you're going to lose your focus. You're going to lose your focus. Other competitors are going to pass you. You're not going to know what happened. You're not going to know what hit you after it's too late for you. So we have an idea of what we have here. I'm going to go to the spectral analysis. And we're going to choose 4 seconds here. Change that. And here we are. So here is the amplitudes and activity minus the artifacts for the most part. And then ahead we have slowing in the alpha range below 10 hertz. So it's about 8 hertz, 9 hertz. So slow alpha presenting it's diffuse for the most part everywhere. And that means that we have a connectivity issue. When someone has a TBI and there's been axonal and neuronal damage, what the brain does is to try to reconnect. That's what it's programmed to do. The problem is that the brain gets in such a rush to reconnect that the alpha gets reconnected and comes back with a vengeance. And so it's reconnecting, but it's not reconnecting properly. So what we need to do is retrain those networks to reconnect more efficiently and have the brain do things in a better way, to reconnect in a more efficient way, so that it's going to help this athlete perform better. And the slow alpha is just creating a lot of cognitive issues for this person. Memory. We have hyperfusion here at T3, which normally correlates with migraine headaches, which the athlete reports. Tip of the tongue phenomena. F7 is your Broca's area, language production, A, B, C, 1, 2, 3. And so tip of the tongue phenomena, forgetting the word, not knowing the word, not knowing what I'm going to say, sometimes stammering, stuttering, and a lisp that could present too. So the athlete does not have a lisp. There's no stammering, there's no stuttering, but there is definitely tip of the tongue phenomena, forgetting the words. I have the word at the tip of the tongue, but I cannot say it. and somebody else reminds me what the word is, or I just remember it a few minutes later or a few hours later. And here's the compromise on the memory, verbal memory, short-term verbal memory, T5, Wernicke's area, and the headaches. So there's a compromise in language reception, language understanding, and language production, semantic processing, generation of sentences, generation of words, finding the appropriate word, having a flowing, eloquent, continuous speech, and he does have a little bit of slowing in his speech, which has been compromised. Now we got FZ to F4, and we have the discharge, which is in the theta around 5, 6 hertz, with the alpha that goes along with that. So, and we have some high beta and high beta that go along with that as well. So we have some beta spindles that we saw, frontocentral beta spindles, which are a marker for anxiety. And then we have this. So we're going to map this. And here it is, FZ to F4, around 6, 7 hertz. And we'll mark it here as well. And there it is. So as the discharge, we have some right brain slowing as well, which is mostly sociable, the verbal, non-verbal side of it. Occipital slowing, which is affecting the visual field, which the athlete reports. His eyes get tired after a while, his vision gets blurry. And so we have probably the coup and the contra coup here. So the initial impact on the left side of the brain, followed by the contra coup on the right side of the brain, and the vibrating and reverberation of that tearing of networks and neurons that it's affecting his current performance, with the possible compromise here of corpus callosum and interhemispheric communication, executive functioning, inhibition, impulse control, and affective emotional regulation. So that's an idea of what we're getting here. And if we go to the topographies, then we're going to see the slowing, the alpha range, in posterior temporal, some parietal, and occipital. So it's going to be emotional affective regulation, memory, social skills, withdrawing, visual field. And if we scale a little more here, we have theta alpha F3 to F4 discharge from the midline to the right brain, more so than the left brain as we saw in the raw EEG, and some of the beta spindling. That could be some EMG tension, but it's the beta spindling taking place over there. Now we do 2 hertz bins here. We're going to see it clearly. So here it is, FZ to F4 discharge. Here's your F7, T3, T5, and your T4, T6, O1, O2, PZ, compromise. I want to go back to the spectral analysis for a second because I want to do a PZ. Look at the peak alpha frequency. And here it is. So this gentleman is around 30 years of age, still young, but his peak alpha frequency is below, if I get the right pick, is about 8.79. We go to the table here to confirm. So it's 8.79 hertz, which is low for his age, which confirms that there's some cognitive compromise, procedural memory, semantic memory. The brain processing speed is compromised. So in addition to enhancing performance, we need to look at the cognitive aspect. And here's all the alpha and different sites. So it's at the average is 8 hertz, which is low. We need to speed it up, do some 12 to 15 SMR type, beta type training to speed up that brain if we want to do some cognitive enhancement. Now, since PZ is compromised, it's the cognitive performance not only pertaining to his athletic ability, but pertaining to his academic and work ability. And he's a business owner. He has his own business. He's got employees and has reported feeling problems at work, getting tired more quickly, getting tired more often, having trouble for remembering things, forgetting things, giving directions to his employees. So as we can see, not only it is the athletic aspect of things, but also the personal, the business aspect of things that we have to take care of. We're going to go back to our spectral analysis for a second here. Do the full EEG for the eyes open. And go to the topographies here. So we're going to do now the theta to beta ratio. And there it is. So we got about 3 to 1, 3 times more beta, theta than beta, sorry. And that's the midline. That's fretting, emotional regulation, attention and concentration, focused, stay focused for long periods of time, fretting, cognitive flexibility. So, being driven a little bit by the slowing here, the posterior side, the coup and the contra coup, but we have some activity right there. And so that's for the eyes open. So we have a clear idea what's going on here and what we need to do. So the beta spindling, fast alpha. And so now we're going to look at the eyes closed. So here's the eyes closed EEG for the athlete. And once we glance through it, we're going to see that the EEG with the eyes closed is going to be relevant. We have some stage 2 sleep early on in the recording, 40 seconds. Probably beginning, there's your T5. Slowing again. And start seeing some stage 2 sleep right here, early in the record, which means he's falling asleep when he's not supposed to. Got even more slower right here. Look at FZ to F4, midline with that source, that triggering, which is not a good thing. And if we start looking at the midline, we're going to have that sharp vertex wave that we've seen in other interpretation before, which is the sign of a sleep disorder. So I would have referred this client to a sleep clinic for a sleep study. He already had one, and he has a diagnosis of sleep apnea, which is probably the most dangerous of sleep disorders, because it means that you could stop breathing in the middle of the night and die in your sleep. So he's being treated for that. There's this sharp vertex wave. You see it once, you see it again. Here's the slowing, stage 2 sleep. So alpha disappears, theta spotters, and there's your recipe for disaster. So in addition of having cognitive difficulties because of the TBI, the discharges, the slowing, we also have a sleep disorder, which is clearly diagnosed as sleep apnea. Now, one of the things that happens with athletes is that because they produce more elastin, which helps the muscles become more flexible and stretch out more, they're going to have a problem because the palate muscles are going to relax a lot more, causing the obstruction of the airflow. So that's something that needs to be taken into account, because this athlete is not overweight. He's fit. He does a lot of workout, and he's got a good body mass index, which is within the normal patterns. But it is the relaxation of the palate muscles that probably is causing the problem. So he's doing the treatment with the mask for the sleep disorder, and then we'll do some neurofeedback to assess that as well. Some training with neurofeedback. So here you have it, some overall interpretation for this athlete, and I hope it was useful. It certainly was useful for him, and we will do another one pretty soon. Thanks for your attention.